All right, let's jump straight into rapid pulmonary triage for step 2 and 3. We are building a strict, no-fluff clinical algorithm in your head right now. We're going to move fast, from basic PFTs all the way to complex ventilator mechanics and toxicological emergencies. If you want to efficiently master exactly how to interpret these presentations when that exam clock is ticking, well, you're in the right place. Let's get into it.
Picture this. You've got a patient who is short of breath, and you get their pulmonary function tests. Where exactly do your eyes go first? On test day, you really can't be looking at everything at once, right? You need a laser-focused algorithmic approach to just cut right through the noise. You are looking for the primary branch point. So, your immediate first step? Look at the FEV1 over FVC ratio. This one single calculation literally splits your entire differential diagnosis right down the middle. It tells you instantly, are we dealing with airways that can't get air out or lungs that can't get air in?
Let's break that down. Obstructive lung disease is defined by an FEV1 to FVC ratio that drops below 70% of what's predicted. The airways are narrowed, so that forced expiratory volume just plummets. Restrictive patterns, on the flip side, maintain a normal or, hey, even a high FEV1 to FVC ratio, but the overall lung volume, the total lung capacity, or TLC, is significantly reduced. They just can't fit the air in. Now, if you need to definitively diagnose asthma versus COPD on test day, it all hinges on the bronchodilator response. Asthma absolutely requires a reversible response. Specifically, we're looking for at least a 12% and 200 milliliter increase in FEV1 or FVC after hitting them with a short-acting beta agonist like albuterol. COPD? Yeah, that typically doesn't fully reverse.
So how do we visualize that obstruction? Well, a classic flow-volume loop gives us two really critical features. First, take a look at that signature scooped out or kind of coved shape during the expiratory phase on the top half. Because the airways are prematurely collapsing while the patient exhales, the flow rate just drops off drastically. Second, notice how the entire loop has shifted to the left towards higher lung volumes. This is your classic hyperinflation and air trapping. The patient is basically breathing in a much higher baseline volume because they literally cannot empty their lungs completely.
Now, contrast that last one with a fixed upper airway obstruction. We're not talking about a lower airway issue like asthma or COPD anymore. This is a blockage much higher up. Think tracheal stenosis or maybe a massive goiter. Look at that box-like shape. Both inspiration and expiration are totally flattened out and truncated. The flow is basically capped at a maximum rate, and it doesn't matter how hard the patient tries to breathe in or out. The physical diameter of that upper airway is rigidly narrowed, and it's just not budging.
Okay, so once you've nailed down whether it's an obstructive or restrictive pattern, you use the diffusing capacity, or DLCO, to isolate the specific disease. DLCO basically measures how well gas transfers across the alveolar capillary membrane. In obstructive patterns, a low DLCO is your decisive clue. It separates emphysema, where the alveolar walls are physically destroyed, from things like chronic bronchitis or asthma, where the DLCO stays normal or might even go up. Now, what about restrictive patterns? A low DLCO points you straight to interstitial lung diseases, like sarcoidosis or asbestosis, where that barrier is actually thickened. But if your restrictive patient has a normal DLCO, the lungs themselves are perfectly fine. The restriction is coming from the outside, like a severe chest wall deformity or a neuromuscular weakness.
Let's shift gears from chronic dyspnea to acute hypoxemia. Your triage here has to be equally rapid. When a patient's oxygen is tanking, run through this logic immediately. First step, check the AA gradient. That's the difference between alveolar and arterial oxygen. If it's normal, the lungs are doing their job, but the patient is either hypoventilating or they're just at a really high altitude. But if the AA gradient is elevated, you've got a gas exchange problem. So your next question is, does the hypoxemia correct if we give them supplemental oxygen? If yes, you're looking at a VQ mismatch. Think pulmonary embolism or diffusion limitation. If it does not correct with oxygen, boom, you're dealing with a shunt. Blood is entirely passing the ventilated alveoli. This could be an intracardiac right-to-left shunt or an intrapulmonary cause like severe pneumonia, pulmonary edema, or atelectasis.
Right, so if that hypoxemic patient fails to improve, they're probably ending up on mechanical ventilation. Let's transition into critical care and dissect the ventilator pressure waveform, because this curve is an absolute gold mine of data. At the very top, you have your peak inspiratory pressure, or PIP. This is the max pressure needed to shove air through the tubing, the large airways, and into the lungs. But notice what happens when the vent pauses and holds the breath for a second. The pressure drops and levels off. That flat line right there is your plateau pressure, or P-plat.
This is absolutely crucial to understand. The plateau pressure is the elastic pressure of the lungs themselves when there is zero airflow. The difference between the peak and the plateau, that's your airway resistance.
So why does that difference matter? Because it gives you the highest yield troubleshooting logic when a vent alarm starts blaring for high airway pressures. If the peak pressure spikes, immediately check your plateau pressure. If the plateau is totally normal, your lung compliance is fine. The problem is purely a resistance issue. You're thinking bronchospasm, a mucus plug, kinked tubing, or maybe the patient is just chomping down and biting the tube. But if both the peak pressure and the plateau pressure are sky high, you've got a severe drop in lung compliance. The lungs have become incredibly stiff. This tells you to immediately look for a pneumothorax, pulmonary edema, worsening pneumonia, or ARDS.
Speaking of ARDS, acute respiratory distress syndrome means a massive drop in lung compliance, and managing it requires really strict adherence to lung protective ventilation. Because those alveoli are filled with fluid, the functional, usable size of the lung is drastically reduced. You absolutely must avoid overdistending whatever healthy tissue is left. How do we do that? By setting a strict, low tidal volume, exactly 6 milliliters per kilogram of ideal body weight. On top of that, you have to continuously measure that plateau pressure with an inspiratory hold and make sure it stays under 30 centimeters of water. If their oxygenation is still poor, don't just blindly crank up the fraction of inspired oxygen. Instead, you increase the PEEP, the positive end expiratory pressure, to recruit those collapsed alveoli and pop them open.
Alongside pressures, you've got to constantly keep your eyes on the end-tidal CO2, or capnography. The actual shape and presence of this waveform gives you instant feedback. For example, a sudden complete loss of the end-tidal CO2 wave, that is a catastrophic red flag. It usually means the endotracheal tube has been completely displaced. Maybe it slipped into the esophagus, or the patient just went into cardiac arrest, or had a massive PE that abruptly stopped pulmonary blood flow. On the other hand, what if the waveform is there, but it loses its nice sharp angle, like phases 2 and 3 become all sloped and prolonged? That is your classic diagnostic clue for severe bronchospasm. Physiologically, the air is really struggling to get out, and that smoothly drags out the CO2 exhalation curve.
Now let's look at a classic toxicology pitfall. This one perfectly mimics critical respiratory failure, but actually has entirely normal ventilator mechanics: methemoglobinemia. Imagine a patient gets exposed to an oxidizing substance, like dapsone, nitrites, or maybe a topical anesthetic. They show up looking blue, totally cyanotic, and their pulse ox is hovering stubbornly around 85%. And it doesn't matter how much oxygen you pump into them, it won't budge. Here's your diagnostic eureka moment. They have a massive saturation gap. When you draw an arterial blood gas, the PaO2 is completely normal. Standard pulse oximetry just cannot read methemoglobin accurately, giving you that falsely low reading. Oh, and if you actually look at the blood during the draw, it'll be this weird, dark chocolate brown color.
Let's pull all of this together into a rapid-fire clinical scenario. You're standing at the bedside of a ventilated patient. Suddenly, the monitor starts screaming. Their end-tidal CO2 has precipitously dropped. The vent is blaring. The peak inspiratory pressure is soaring. You quickly do an inspiratory hold, and you see the plateau pressure is equally high. Okay, what just happened? Well, the high plateau tells you lung compliance just plummeted. That sudden drop in CO2 tells you pulmonary perfusion has been drastically cut off. So you're not dealing with a simple mucus plug here. You are likely looking at a sudden tension pneumothorax, causing cardiovascular collapse, and you need to prepare for immediate needle decompression. But what if that sudden CO2 drop happened with perfectly normal airway pressures? What massive vascular catastrophe just occurred, and what exactly is your next diagnostic move? I'll leave you to think about that one.